physically. So we're trying to think of different ways that we can reach people and help people to understand hospice, what it is truly now versus what it used to be, 10, 15, 20 years ago. And I realized that, myself, I have a freshman in high school and a freshman in college, but my parents moved in right next door to me, literally right next door to me. And my dad's 82 and my mom's 72, and they're very active, and, they're doing a lot of work on their house. But I noticed that there's a lot of people in our township that are either my age, so soon to be, or in the middle of helping their parents, grandparents, in-laws through this next journey. Or, their parents, they're either helping their parents or, their parents in the community, elderly in the community, going through it themselves. So I thought it was a great opportunity for us to kind of pull together and hopefully answer any questions that you have. And we will be giving Jason, we'll have all our contact information for him. So if there's any, we have so much literature, we have a website. Carla and I are both available as resources to you. So we'll make sure that Jason has all that contact information. Hopefully when the township building opens again, we can put some of our information there. So with that said, I'd love to introduce Carla. She's our clinical liaison / educator with Compasses Hospice.
Hi, everybody. Good evening. Thank you for having Deb and I. As a nurse, I'm always looking for opportunities to educate the community, especially about hospice. So as a nurse with hospice, I've been doing this for the past 10 years with Compasses. A little background about me. I was their on-call nurse for several years. I was a nurse case manager for several years. I spent a little bit of time as a director, and my current role as the nurse liaison, I've been in this for 4.5 years. So I have a passion for people, but I also have a passion for education. So when I say that word, even to my own family, when I first started working with hospice, I got so many responses. My own father-in-law said, I can't believe it, you're going to be Kevorkian. And I just sat there and thought, wow, like people still think that, and I took it very seriously though. At first I chuckled, then I thought, wow, do you really believe that? And he really did. So there are so many myths that are still very much alive about that word hospice. And I'm going to get into the myths, but first I would like to review what the hospice benefit is. So it was founded in 1974. Medicare started rolling out the hospice benefit and the rules in 1980. So if you are 65 and older and you have Medicare, and if you qualify for hospice, this is a free benefit for you. If you are under 65 years old and you have private insurance, you may or may not have a hospice benefit. Private insurance dictates what it wants to cover, as we all know. But if you are, and I want to correct myself, it's Medicare and Medicaid. So anybody with Medicare or Medicaid, it's a free benefit when you qualify. Private insurance, you would have to look into your benefit. So just to keep it simple, we'll talk about that 65 and older Medicare or Medicaid patient where it's 100% free. So as we get advanced in age and we naturally decline, it's very important that people are aware of their healthcare benefits because we all pay for them. So that's a big thing that I do every day is try to explain to people what the benefit is. It is a insurance benefit. So if we can take that word and sit it on a shelf for a minute because it scares people, and if we could focus on the benefit. So for that term hospice, when a physician writes the order and says a patient has a diagnosis or, I'm sorry about that, a life expectancy of 6 months or less. People think of that term too as if it's written in stone, and it's not. So what that means is if somebody is declining from a chronic condition or multiple conditions or something sudden or acute, and the physician feels that if things continue to decline naturally, they could have a life expectancy of 6 months or less. It does not mean they will definitely pass away in 6 months because we do not have a crystal ball, right? So if this person has Medicare and they qualify for hospice services, they are now entitled to more services for free under their Medicare benefit. This hospice team goes to wherever the patient lives. So sometimes people think hospice is just in a building, a hospice building. But at Compassus, we provide the service wherever the patient lives. If they're in a long-term care nursing home, if they're in assisted living, if they live with their family and they live at home in their apartment or independent home, wherever they live, that's where they get the service. So if they qualify, they get this hospice team that's going to go in and layer in extra care services, and it's all free. So they're going to have a team available to them. They're going to have nurses, aides, chaplains, social workers, volunteers, and things are a little different now with COVID, but I'm going to speak about the benefit as it exists under the Medicare rules and regulations. So what that looks like, if somebody lives at home with their loved ones and they qualify for hospice, a hospice nurse will come out and check on them once or twice a week at a minimum, and more often if they need it. So at 10 o'clock at night or 2 o'clock in the morning, they don't feel good. Their only option is not going to the hospital. Medicare says they now have extra services, and they have hospice nurses that are available to them 24 hours a day. So hospice is not in the home 24 hours a day. It's a supplemental support service, right? So that nurse checks on that patient once or twice a week. She's there maybe about an hour or so, but anytime the nurse is not with the patient and the family can pick up the phone and have access to nurses 24 hours a day for any urgent needs. So if we look at a patient who has COPD, they're living with a chronic lung problem. Research shows that in the last year of their life, they often go back and forth to the hospital for symptom management. So if we look at somebody who has end-stage COPD, they can no longer cure their disease. It's irreversible. That's when you're talking about hospice. When curative measures are no longer an option, when the patient no longer wants curative measures or aggressive interventions. So in most cases, when somebody qualifies for hospice, they're usually just doing symptom management. It's not like there's a surgery to correct it. Things are irreversible, and it's going to take its natural progression. Nothing hospice does is going to shorten their life, just like nothing the family does will shorten their life. So when they qualify for hospice, they have access to these services to make sure that all of their needs are met as quickly as possible. And we're talking about their physical needs, their emotional needs, and their spiritual needs. Hospice is looking at a person as all of those things together. We don't just look at the person and want to do physical symptom management. We want to look at each individual person and see and find out what are their physical needs with their disease process, what are their emotional needs, what are their spiritual needs. If we look at pain, a lot of people are in pain, and it's not just physical pain. They could have spiritual distress, emotional distress. They're separated from their family, especially under these COVID restrictions. Deb and I talk to facilities and doctors and nurse practitioners and experts all across the communities, and we talk to families every day. Families that can't go into the nursing home, hospitals, places where their loved ones are living, they can't visit them, right? So we're not going to change that. But if somebody qualifies for hospice and the hospice team can go in and provide extra services to their loved one, and also call the family and keep them updated about what's going on, it can help tremendously. When I think about hospice, I always think about, and I talk to families from this perspective. If your loved one, their health is where their health is. You get to a point where it's not reversible, but we don't want to take away hope, right? So that's the other thing. Sometimes people think if they come on to hospice, everyone's going to give up and give up hope. And that's not true. Everybody should have hope and hope planning every day of their life, all the way up until the end of their life. But let's say somebody has a life expectancy of 6 months or less. If they come on to hospice, they're not going to die any faster. But the hospice team providing all these extra services could very well change the way that person lives the rest of their life. Our focus is on improving quality of life, making sure that they're free from pain, that we're looking at their own anticipatory grieving. We're giving them an opportunity to plan for their own end of life, which is so important. I'll sit with patients and I'll sit with their families, and no one wants to talk. Like, if, let's say the person has cancer, no one wants to bring up the hard questions. No one wants to talk about things. They want to keep everything happy and peaceful. But it's very, very important to have somebody who's going to sit with that patient and allow them the platform to talk about what are their own fears. What do they think about at the end of the day? Because if somebody has a life expectancy that's terminal, nearing end of life, we can't hide that from the person. Dignity and respect means that we allow that person the opportunity to have all of the correct knowledge about their healthcare so they can direct their own healthcare and make their own decisions what they want their life to look like. And that means how aggressive they want their treatments to be, and sometimes if they opt out of treatments, to support them and say, that's okay. They don't have to have treatments if they don't want to. So giving that person the ability to really share about, well, first understand their disease process, and two, share if they have any fears or concerns so we can educate them, ask them about their emotional needs, their spiritual needs, their past. Our past experiences contribute very much to the way that we handle our current experiences. So we need to allow people to share in that way and support them right where they're at. So I'm going to recap real quick about that hospice benefit because it's a lot of information. And like Deb said, we have literature out there. We have a website. We're both available as questions come up, both tonight and after tonight. So hospice is a benefit where you have to be eligible. A doctor has to say, yes, this person could have a life expectancy of 6 months or less. The doctor writes the order, which allows hospice to go out and see that patient and evaluate them and determine if they're eligible. If they are eligible, the hospice team starts layering in those services wherever that patient lives, whether it's a nursing home or whether it's at home. That hospice team consists of nurses, aides, social workers, chaplains, volunteers. A big thing is that there are nurses on call 24 hours a day. Just the other day, I had a nurse in a building say to me, I understand that, we'll call her Mary Smith, is on hospice, but when she has trouble breathing, I want to call 911 and send her to the hospital, even though she's on hospice. And I explained to that nurse, okay, let's go through that together. If somebody can't breathe and you call 911, they have to wait for an ambulance to get there. They have to take the ride to the hospital, wait to be assessed by doctors who don't know them, all the while they can't breathe. So if they have a chronic health condition, we know that the chance of this happening is very likely, and it could keep happening over and over. So that's very unfair to somebody who has a chronic condition that they have to rely on a hospital system where for trouble breathing and things like that, you're waiting for symptom management. The other flip side of that is you pick up the phone, you call your hospice team. That nurse is right away on that phone. Hospice has already pre-planned for this, so they have emergency medications already in place, and they're telling the person on the other end of that phone what to do while they are driving en route to make a visit to that patient. So the difference is time. If I couldn't breathe, would I want to wait 30, 45 minutes, an hour and a half, depending on how busy the hospital is, before somebody helps me breathe? Or do I want to pick up the phone and have a nurse on the other end who has already developed an emergency plan for me, tailored just for me, where I can have symptom management immediately? So there's a very big difference. I'm going to go now into some of those myths, okay, because they're very much alive. We hear from patients, families, and even medical professionals. You know, we assume that medical professionals should understand hospice, but if it's not their area of expertise, or if they don't have a lot of experience in their type of medical practice, they may not understand hospice. So Deb and I deal with that a lot too, helping physicians and nurse practitioners, you know, clinicians better understand the benefit because they don't always understand it. So one big myth that's very much alive with hospice is, the very first one is, I'm not ready to go on hospice because I'm not ready to give up on my dad. So we hear that all the time, where hospice means giving up. Hospice does not mean giving up. Again, if somebody has health problems and health decline, it's out of everybody's hands. If they've gotten to the point where no more can be done that's going to reverse it and change it, but it's more about using medications to keep them comfortable, things like that, then they're coming on to hospice to make sure that they have these emergency plans, these extra services in place for them. And that's very important. Another big myth that we hear all of the time is, if my loved one goes on hospice, I lose all control. Nothing is in my control anymore. Patients will say that to us, and families will say that to us. So I had a gentleman who was a veteran. When I sat and I talked to him about the hospice benefit and his prognosis, which the doctor had already talked with him about, the very first thing I asked him was, when I say the word hospice to you, what does that mean to you? And that's what he said. It means giving up, and I'm not ready to give up. And I said, tell me about the fight that you have every day. So he had cardiac issues, congestive heart failure, and other cardiac conditions. To him, what it meant to fight was, I want to be able to continue to walk. I want to be able to continue to live like my life with dignity and as much independence as possible. I don't want to die. Most people don't want to die. And on hospice, we're not just preparing for their end of life. We are helping them manage everything related to their disease process every single day, for every day that they still have available, whether that's 2 weeks, 2 months, or 2 years. Our job is to make sure that we are helping them and giving them these services. So that's another big thing that we hear, is giving up. Our hospice team is very focused on living. I want to live until the very last breath. Most people want to live that way. We want to fully live to the best of our abilities. So it's very important that people understand that hospice is not about giving up. Hospice is about supporting the patient and the family. And it's about celebrating every day that they have and helping them to have the most quality and comfort and support every day. Another myth that we hear is, oh, if I go on hospice, you're going to start morphine, and then my loved one's going to die in a couple days or a week. And that comes from somewhere. So I always ask them, what has your experience been with hospice? And when somebody thinks that we're going to start morphine right away and the person's going to die very quickly, the most common response that I receive is, well, My aunt was on hospice and they started morphine and she died 6 days later. I hear stories like that. So for those stories, I always say, if somebody comes onto hospice and they pass away 6 days later, they were already in the very last days of their life. And if they didn't come on hospice, they still would have passed away in 6 days. That person came on at the very, very end of their life. We still service patients even if they only come on for 1 day. But our goal is to make sure that if they qualified a month ago or 3 months ago or 6 months ago, that they have access to this benefit so they can utilize all of those services for the most time that they can. But sometimes somebody has a rapid decline. Something happens very suddenly where they were pretty stable and healthy, and maybe a week before they did not qualify for hospice, but they had a sudden heart attack or a stroke or something that happens very suddenly, and all of a sudden they are eligible for hospice and they're at the very end of their life. So if somebody comes on and they're receiving morphine at the very end of their life, the morphine did not cause the end of their life. So morphine is a very buzz word. People think of hospice, morphine, and end of life. Morphine is used in a lot of cases when patients are in the last phases of their life, and especially when they're in their last days of life. A lot of patients start to have respiratory problems when they're nearing the end of their life. Morphine is the #1 medication for respiratory distress. So if somebody is struggling or having trouble breathing, what morphine does is it goes in and it relaxes the muscles and it slows down the breathing. It can't change the outcome. If that person is in the dying phase, the morphine cannot reverse it. Nothing can reverse it. The morphine is used as symptom management. So it can help with breathing problems, and it also can help with pain. So sometimes at the end of life, people are in their bed more, they're not moving around more as much. So think about if you've ever been sick and you're laying in bed for days. Pain starts to set in, your back hurts, your legs hurt. So if somebody is nearing the end of life and they have pain issues, we can use morphine to help them with their pain. We do not over-medicate patients. We do not assist patients in dying. Nothing we do can hasten their demise. We are not an assisted suicide state. So to the flip side, sometimes we get families who are so in distress, or patients that are so in distress that they ask us, can you start the medication and help this along? No, we cannot. People have a natural decline. We are a hospice company. We are not allowed to speed up the dying process. We are not allowed to over-medicate patients. We work very closely with the patient's physicians, as well as the hospice physicians who oversee all of the care, all of the medications, so that, nothing is going to be too aggressive. We are allowed to do symptom management. We are not allowed to hasten demise or expedite the dying process. It's a lot of information, right? I hope that what is falling on everybody's ears is some key things. If you have a friend, a loved one, or you yourself has chronic conditions, declining health, and you would like to be evaluated, or you would like your loved one to be evaluated for hospice services, or you want to talk more about it, you would talk to your physician. You can contact our hospice company anytime for education. At Compassus, our vision and our goal every day is not just that minute when that person comes on to hospice. We want to support the community in all the ways that lead up to end of life. And sometimes that's a year or 2 years before somebody qualifies for hospice. And they reach out and they want education. They might even want to be evaluated, right? So if they're not yet eligible, that's okay. I would rather evaluate somebody and then be not yet eligible and keep an eye on them than for someone to not be evaluated and be appropriate and not know. Hospice does not make decisions for the patient or the family. The patient and the family do not lose their control. Hospice is a resource. The patient and the family make their own decisions, direct their own health care. And sometimes people say, if I go on hospice, that's it. What if I change my mind? You have a right to change your mind every day. Nobody's going to take your right away from you. If somebody comes onto hospice because they qualify and they're no longer seeking aggressive treatments, or there's no longer life-sustaining interventions available to them, and maybe 2 months down the road, all of a sudden, there's this new intervention that somebody developed and they want to try it and it's very aggressive. That patient and family has a right to change their mind and come off a hospice because they no longer want a comfort goal. They want to do aggressive treatments. So they have a right to come off a hospice and go and change their plan of care and do aggressive things. That's their right. So you have to be eligible. You would coordinate and collaborate with your physician. You can reach out to Compassus for questions, for more information, anytime. If you come on to hospice, you do not lose your right to choose. No one is going to hasten the demise. We are not just going to pump people up with morphine and things like that. We have many patients that never use morphine at all. Every patient is looked at as an individual. Their plan of care is developed with the patient, family, the hospice team, and their physician. It's a collaborative approach. No two patients are the same. If you take 100 patients who have heart disease, they're all going to be somewhat different. We all have different factors that play into our health. One person might have diabetes and heart disease. Another one might have COPD and heart disease. Someone else might just have 5 different types of chronic heart conditions going on. So we are all very different. And our approach at Compassus is to look at each individual patient and develop the best plan for them and hear them. That family and that patient drives their care with our team. We do not take over. We're working together to make sure that they're comfortable and they're managed. A statistic I would like to share, just to kind of put things in perspective, about 50% of people pass away without ever utilizing hospice. That number has not changed that much in a while, in several years. And in healthcare, we've done more to try to educate and have access. We're always getting out there trying to talk about the benefit, dispel the myths, take the fear away from the word. And still 50% of people pass away without hospice. As a nurse, that upsets me. Because it's not that 50% of people understood that they could have hospice and chose not to. There probably are some, but not 50%. So that means that a good chunk of that 50% either did not have access to it, did not understand the benefit. Maybe their doctor didn't understand when to refer to hospice. There's lots of things. Maybe the family said, oh no, not yet, not for my mom, not yet. We hear that a lot too. They want to keep waiting and waiting, and then sometimes they miss out. So if the hospice team is not going to do anything to hasten demise, and we're going to support that person, it's a wonderful benefit. Research also shows that when somebody comes onto hospice early, not that person who's already in their last week of life or 2 weeks of life, but maybe somebody that comes in and they're on hospice for 3, 4 months at the end of their life. They could live an average of 28 days longer. And the reason why is because we are looking at all of their symptoms. We're looking at them physically, emotionally, and spiritually. When somebody has chronic pain, whether it's physical pain, spiritual pain, or emotional pain or distress, it puts stress on the entire body and they decline faster. That is a fact. That's why if anybody here has ever had surgery, what does the surgeon say to you? When you go home, I want you to take this pain medication just as it's prescribed. And the reason why is they want you to keep that pain managed, because if your body is under so much stress with the pain, it stresses out the entire body and you don't heal properly. So if we have people that come on early to hospice and we can make sure that we're addressing all of these issues, research shows they could live 28 days longer. So that takes away from the myth that we are going to end their life quickly. We have nothing to do with that part. There's a few things I want to say before we have questions. There are other things that are covered in that hospice benefit. So you get this team approach, right? You have nurses, aides, chaplains, social workers, volunteers. The benefit also covers medications. So for some patients, most of their medications are paid for, and other cases, all of them are. So every case is different. If the person needs medical equipment, hospital bed, a wheelchair, bedside table, oxygen, a commode, walkers, all of this medical equipment is part of the hospice benefit. There's no cost. It's delivered to the patient wherever they live. If it breaks, we replace it the same day. If the patient has incontinence, so if they wear pull-ups or briefs, that's covered under the hospice benefit, which is a huge thing. When families are paying for them or patients are paying for them, it's very expensive. So if they qualify for hospice, it's covered, right? So all those things really help the patient and the family. It relieves a lot of the financial burden that can build up. So it helps to pay for the medical equipment, helps to pay for medications. It helps to pay for incontinence supplies. Well, we deliver them to you. They're pull-ups and briefs and things like that. If the patient has wounds, the hospice takes care of the wounds and they cover any wound care supplies. I know that we're going to do some other discussions in the future. So at another time, we are going to have a focus on veterans, but just so people are aware, if you are a veteran, your hospice benefit looks different. You get to keep your veteran benefit and you have a hospice benefit. So we're going to talk in the future more about that, veterans, but just to plant that seed, if anybody's a veteran, they have a double benefit because they never lose their veteran benefit and they also get to have their hospice benefit. Does anybody have questions, or did anybody send anything in to you?
He's on mute.
Okay, now I'm off. Now
there you go.
Yeah, I think we had a couple of questions come in,
Okay.
but they're a little kind of unclear on what they're asking. I actually had one question too. I have some family in other states. So, Maryland, California, North Carolina. Are there any differences if my wife and I are here in Pennsylvania taking care of somebody else in another state? Are there any kind of issues, across state boundaries or state laws that might govern hospice in different areas? Or
are you asking me if they still have access in another state to hospice?
Well, just if there are any other hurdles that we would have to take care of being here in Pennsylvania. Are there any additional steps to take care of somebody in a different state that would,
No. So if let's just say you have an aunt in another state and she's going to start hospice in Florida, and you're the caretaker and you're involved. They would do everything by phone with you and email. That's what we would do. We have lots of patients who their families, they have multiple children. One might live local and two might live in 2 other states. So, they're part of the plan of care and they're involved. So we call them and we keep them involved. Every state might have some differences under the guidelines, but they're going to be small things, nothing big. Everybody has access to hospice, and it generally looks the same.
Yeah.
If, that particular state does their paperwork slightly different, things like that. But no, they still have access.
Medicare. It's all under Medicare guidelines. So
Right.
the premise of hospice, even in Pennsylvania, all the hospices are under the same Medicare guidelines. So all the principles are the same. What sets every hospice apart are the team that's involved, the additional services that they provide, things like that. So that's the only thing you want to do from a distance is make sure that you have different options.
Yeah, and to interview, just like anything. You have a doctor, you wouldn't just walk in, but maybe your neighbor referred you to a doctor. If you get there and that doctor doesn't feel right, you wouldn't work with him. You would go find another doctor, or maybe you're going to interview 2 specialists. So hospice is the same. People have choice. They need to feel comfortable with the team and the company that's taking care of them. And if they don't, they have a right to pick another company. If they're already on hospice, they have a right to fire that company and switch over to another company, just like you have a right to fire your doctor and pick a new doctor.
Yeah.
Okay, that makes a lot of sense. And I don't know if you can hear me. I couldn't quite get what your question was. I think you were talking about maybe like having somebody get set up for hospice. Can you hear me, Ann?
Yeah, Jason, can you hear me?
Oh, yep, I can hear you now.
Okay. Both my mother and father and my mother-in-law went through hospice. With my mother-in-law, she had metastasis, and it was wonderful. Hospice was absolutely wonderful for her. They came in about a month, maybe a month and a half before she died, and helped her get everything in order and, in her head and otherwise. And it was wonderful. When my dad went into hospice, that was about a month before he died, I guess. It was obvious that he was, it had been obvious for a couple months that he was on a downward spiral. And I don't know why they would not approve the hospice before then. I know my mother and father tried, but they were trying, I guess, 3 months out, but they only approved of it a month out. Excuse me. And then my mom was in hospice very briefly, like a week and a half. She was 102 and fell and broke her hip, and it was just awful. And they really should have had her in the hospice. Is it something that we have to ask for, or should they mention it?
Very good question, Ann. Your doctor should, whoever's involved, the nurse practitioner, the doctor, they should be recommending it at the right time, but they don't always know. It goes back to, what is their experience? And, I had a doctor say to me recently that he wasn't ready to give up hope. And he said, I don't want to bring it up to the patient because I don't want to break the patient's hope. And my response to him was, well, that's not fair to the patient, because if they really only have, this patient had 4 to 6 months to live, he thought. So if this patient really is only going to live for 4 to 6 months, you're breaking hope by not being honest with them. Because if you wait too long to tell them their diagnosis is terminal, they're going to have less time to prepare, and that's not fair to the patient. So a lot of doctors either don't feel comfortable, don't know when, or they think the family really wants to keep fighting. What does fighting really mean? So there's a lot of variables that go in, and unfortunately, people have to learn how to advocate for themselves and their loved ones. And we have to be aware of our rights. So a family has a right to say to their physician, I want to be evaluated, or I want my loved one to be evaluated. If that patient says, no, they're not ready, they're not hospice ready yet, you still have a right to an evaluation. So you can say to your doctor, well, I know I have a right. I want my mom evaluated. Let's see what the hospice says. I want the evaluation. So sometimes families have to have a voice and they have to push. Other times, the physicians are the ones referring. So we do this kind of education so at least the community knows what their rights are. And we get families that call us and say, look, I really think my dad's declining. The doctor doesn't want hospice. I really want an evaluation. This actually happened to me yesterday. So I called the doctor for the family and I said, the family wants you to write an order to have their loved one evaluated. They called our company and this is what they're requesting. And I explained to the doctor, and then the doctor agreed, because sometimes you have to push a little bit. It lets the doctor know, okay, they do have a right to an evaluation. So not all doctors know when.
Real quick, Carla, and there are some physicians out there that won't bring up hospice unless the family brings it up first.
Yeah.
Or they won't recommend hospice or write an order unless the family brings it up. So it's difficult, like Carla said, a lot of time, that's one of the reasons why we're having this Zoom call tonight, is to try and help families in the community. Now, you're part of that club where you've had hospice experience, so you kind of know a little bit more of the ins and outs of what to do. But a lot of times people don't, and they're in the hospital in a very stressful time, or a specific medical event happens, so they're trying to make decisions under distress, and it's even more difficult. So a lot of physicians aren't trained. There's no training in medical school for hospice. It's simply part of their rounds. So we're trying to help educate them as well.
Yeah. And one statistic to follow that up is 99% of physicians agree that hospice is very beneficial for patients. Less than a third of them felt comfortable having the conversation when they did research. And even less than that felt that they had any type of training whatsoever to help them have the conversation or discuss hospice. So that's a big problem, that they're not giving them enough training, because everybody's going to pass away at some point. This is a guarantee. It's not guaranteed that we're all going to get cancer or heart disease, but it's a fact that each person will pass away. So it's very important that we get the training and the education out there.
Well, thank you.
You're welcome. I'm sorry for all of your loss, Anne.
Well, it is what it is. My mother said that at some point she was ready to go. She was 102.
Yeah.
She said, I've lived my life. If I gotta go, I gotta go.
Yeah.
But and I forgot about my brother-in-law. He had pancreatic cancer, and he was not ready to give up. And he got one of those experimental drugs, and actually he ended up living 18 months, which
Wow.
was incredible. Yes.
That is.
And then at the end, we were talking to him about hospice, and he agreed. And he was in hospice like 5 months.
Yeah.
But it was a wonderful experience for everybody. So
Yeah.
people shouldn't be afraid of it.
Yeah, because one thing we didn't talk about is after the loved one passes away, hospice has bereavement support for the family for 13 months. And that's very important. And something to know about Compassus, Anne and everybody else, we have free bereavement support to the community. So anybody can call our office and receive free bereavement support no matter what, whether it's something that happened many years ago and you just feel like you're ready to talk about it, or you need to talk about it, or you need support. You know, we have bereavement support for you and the community.
Well, thank you. That's a comfort to me. Thank you very much.
You're welcome.
I have one other question. So what happens in the off case that the doctor says this person has 6 months to live, they start hospice care, and they go past the 6 months?
Okay. So as long as they have decline that keeps them eligible, you know, it's out of everybody's hands, right? But there's things that keep people eligible. First of all, if somebody comes on the hospice and they qualify, they're not going to graduate off even if they start improving. They're not going to graduate off like a month later. They usually get that first 3 months, right? They've had enough decline, they qualify. If they don't continue to decline over 4 months, 5 months, 6 months, 8 months, right? Depends. Then they would graduate off of hospice. So it's not like you come on and you graduate off 3 weeks later. You usually get that 3 months. Okay? Your first benefit period is 3 months. And that nurse is checking in with the patient at least once a week, usually more often, and they're talking to the family. So the family is very much aware, and the patient's very much aware if they're involved in their own healthcare, of what's going on. So maybe month 8, it looks like they're they might not be eligible for much longer. They're going to be talking about that leading up to it. So it happens. We get patients who graduated off of hospice. The last month, I think we had 3. So it's a small percentage, but it does happen. Most people come on and they continue to decline because they're in that natural decline, but we do get people that they bounce back. They get all these extra help and services. They start to get stronger. They feel better, and they're just doing better, and they just kind of plateau or they improve and they're no longer eligible. So if they graduate off and say they decline a month later or 5 years later, whenever they decline again, they can be reevaluated and they can have their hospice services again whenever they qualify. So there's no length of stay. One person could qualify for 4 months and pass away. Somebody else could be on for 8 months and graduate off. So that does happen because we don't have a crystal ball. And sometimes they've had a couple hospitalizations and infections and falls, and there's all this stuff going on and they qualify. And then 6, 7, 8 months down the road, they're not declining at that rate anymore and they no longer qualify. Does that make sense?
Yep, thanks.
You're welcome.
So we don't have any other questions, but we do have a comment, which is everyone that works in hospice are saints.
Well, we hear that all the time, and I always say no, because everybody pays into Medicare, okay? So this is a patient and a family's right. So thank you for that very nice comment. But as a nurse, I see it as this. I went to school to be a nurse. I chose to go into the field of hospice because that's my passion. And I have to deliver this benefit, like my teammates, to the patients and the families in the best way possible because this is their right. So it doesn't make me a saint, it makes me privileged that I'm going to be invited in at one of the most critical times of a patient and a family's life. And I take that very seriously. There's no dress rehearsal. Somebody utilizes hospice for themselves. They only get it one time. You get one life and you get one passing. So I don't see it as we're saints. I see it as if it's not our passion, then we should leave and go do something else, because we could really change somebody's outcome if our heart is not in it.
Yeah.
Yep. Well, Carla, I can't think of a possibly better way to end the Zoom off of that statement. That was wonderful. That was very, very eloquent, well said, and spot on. So thank you, Debbie and Carla, for joining us tonight for the hospice care. I hope everyone on the call got something good out of it. This was recorded, so we will put on the township website. So definitely we'll get some more ears out here on this great cause. And I thank you all for joining us, and I'll see you guys all soon.
Thank you. Have a good night.
Have a good night.
Bye.
Bye-bye.